Top Bed Talk.
Welcome back to EBPOM Chicago. My name is Feyce Peralta. I'm an associate professor for the Department of Anesthesiology at Northwestern University, Feinberg School of Medicine in Chicago. And it's truly a pleasure to introduce our speaker, Dr. Michelle Humeidan, who's an associate professor at The Ohio State University Wexner Medical Center. So welcome.
Thank you so much.
What a fascinating topic. It really made me think about a lot of what we do or what I do in my clinical practice. Usually working with trainees when caring for the elderly, we discuss drugs. We're very specific. Let's not give midazolam or let's adjust this anesthetic because we're worried about post-operative delirium. But we really don't talk about the things that can be done beforehand. Do you think that one activity would be more effective than another?
I think that's the question. What type of activities are going to reliably give benefit to the patients if they do them, balanced with what kind of activities will the patients find engaging and want to actually do in a very busy preoperative time for themselves. So I think that things that keep the mind active and going and focused on different tasks are probably a common element among whatever activity is most important, but there's still a lot of work that needs to be done on that. Maybe crosswords or picking up a hobby before surgery that you've never done before, or starting to read every day if you've never done that. Those things might work as well, but having a more formal software application that can be done too is a really nice way to go about it in surgical patients. So I'm looking at data right now to try to see if a particular domain that the Lumosity games exposed patients to teases out as associated with risk after surgery for delirium, if there's any in particular, because the different patients, since they play different times, in theory, they'll have a balance across the different domains, but we're actually looking to see if there's anything in there that's an imbalance, because they could choose, they played extra, they could choose what type of games that they did. So we're looking at that data, but I don't have anything concrete at this time. So anything new, anything that keeps the mind active, I think could be of benefit. We'll just have the research work on trying to tease that out in more detail.
The other question that I had related to that, do you think these activities have an additive or a synergistic effect? Would you recommend multiple activities? Do you think that that's going to lead to better outcome, or just focusing on one and doing it well could do the trick?
I could honestly argue it either way. And that's another one, at the end of any good research project, I think you have more questions, of course, than when you started. And just like the last question, like which actual activities are the best ones is one of those. The other one is the timing of it. I really don't know if it would be better to do a small intervention for a longer period of time or a more immersive intervention, but for a short period of time. I just don't know. Very small windows of intervention have been shown in, a report that one comes to mind where they did like a mnemonic training device to kind of get patients thinking like on a memory task. And it was a very short training session that was done perioperatively, and then they looked at long-term cognitive effects, and they saw a benefit in their patients pretty removed from surgery, not looking at delirium, but longer-term stuff from a pretty short intervention. So, it kind of makes me think that maybe something that's more involved, but for a short window might be the way to go. And that would be good too for our patients that really high risk for delirium. They come in with a fracture or something like that, where we don't have a large window to do an intervention on them. I kind of, my gut tells me that immersive setup for a short period of time might be effective, but that's another study that needs to be done, like a dose effect and timing for sure.
In your study, you use a 2-week timeline. Why 2 weeks?
The idea for 2 weeks kind of came from our idea that we needed around 10 hours to have an effect. That was pulled from the literature and some, studies of looking at gaming and when they could see an effect in speed of processing in older patients based on like computer game interaction. And so 10 hours seemed to be the minimum amount of time that you could train and see effects on these and sustained effects on these like pretty sophisticated cognitive testing batteries. So I think that there's just a lot more work to be done. I guess I'll just leave it at that.
It's a good problem for you to have right now.
Right. It's a good problem to have.
Let me bring our panelist to the conversation, Dr. Chuck Hogue. He is the James Eckenhoff Professor of Anesthesiology and Chairman of the Department of Anesthesiology at Northwestern University, so my boss. His research has focused on investigating methods to reduce the risk of organ injury from cardiac surgery, particularly neurological and renal complications. He has received funding from the National Institutes of Health, the American Heart Association, and the Anesthesia Patient Safety Foundation to explore novel methods for monitoring cerebral blood flow autoregulation as a means for reducing the frequency of neurological complications from surgery. So welcome, Dr. Hogue, to the discussion.
I was listening to your questions, Feyce, and I had a couple to add, but the duration is interesting. And what happened is, could there be anything additive? So, prehabilitation in itself with, the triad of exercise and nutrition and psychosocial, certainly this would fit nicely into it. But it's interesting reading this nobody knows what the duration is. It seems like the studies that have been positive have had a pretty long duration, number one. So I think the dose exposure you need definitely needs to be worked out. What happens if you add this to something like exercise? We know that exercise has many beneficial effects on the brains. In fact, I was thinking of, is there any other surrogate markers? We've done some work with brain-derived neurotrophic factor, BDNF, which is made by healthy neurons, but it serves as a marker of synaptogenesis and the strength of synapses. And, we've shown that the decrease during surgery and anesthesia actually predicts delirium. And exercise is one of the few things that can actually improve BDNF if that becomes another surrogate. So it'd be interesting if you could add this to other modalities of prehabilitation.
Yeah.
I asked for your thoughts because I had another broader question I was going to ask you.
That is definitely my bigger intention. And I kind of got sidetracked and didn't directly answer Feyce's last question about the timeline. The 2 weeks was because we had that 10-hour goal. And that was like, logistically, that was the period of time where we were kind of getting patients into our preoperative clinic where I could have access to them and get them enrolled in the trial. So that kind of fits along with doing a more comprehensive program, which ideally would be much in advance of surgeries, elective surgeries, or things that we had the time to really do a proper prehabilitation paradigm with all the things you said, the exercise, the nutrition, kind of medication, comorbidity management, and the cognitive, behavioral stress reduction aspect of prehab too. It would fit nicely in there. I think how much benefit, how long we need to do these things to really have benefit, I think requires us to ask, what do we define as a significant benefit? Because in my mind, even a little bit of any of these things before surgery is better than what we're doing on average. So I'm at OSU right now, and I'm trying to leverage some of the quality improvement work that we've already done in the surgical home realm and enhanced recovery realm to tag these types of cognitive and geriatric prehab efforts like into that infrastructure that's already built, because we really need to be doing it. We're on the beginning phases of that, as are a lot of places, I think, where they're just starting to seriously screen patients for pre-existing cognitive dysfunction, which is a practice we should be doing, but it's not being done widespread yet, even though we know that is something we should be doing to really find those high-risk patients. And we should be looking for delirium post-operatively. So at a minimum, we should be doing those things. And I hope to add into a bigger prehabilitation paradigm that cognitive stuff could fit right in there. I am totally with you. A little bit would be better than nothing, but we have a long way to go before we're there, I think.
Do you have a sense about whether interventions immediate post-op in the PACU or post-op day one, let's say that you cannot capture the patient pre-operatively, You assess them, you do their screening the day of surgery, they undergo the procedure, and then you start those interventions in the PACU or in postoperative day one. Is there any benefit of that?
I think that for the basic delirium management strategies that are already out there, I think there's definitely benefit from doing those. If you don't have an opportunity in the preoperative space to do anything, in PACU, starting right away with getting patients oriented, getting them their hearing aids, their reading aids, making sure that they're oriented to their environment and what's been happening to them. I mean, that stuff can start right in PACU. Don't leave them in this like sensory deprivation because they don't have their hearing aids and things. And then carry that over into the postoperative care in the hospital with just good hygiene around taking care of their schedule and when we wake them up through the night, or versus hopefully not wake them up unnecessarily, the kind of room they're assigned to. Those kinds of things I think we could definitely be doing and have a real impact with that. And those are simple things that can be done. Ideally, we would have an opportunity to do something before surgery, but people come in for emergencies, especially our geriatric patient population. And so if we don't have time, these are other ways we can have a real impact on them and impact you and beyond.
Dr. Hogue, you have dedicated a lot of time studying cerebral autoregulation. So what things can we do intraoperatively for that patient that we are not able to catch before the surgery to start these interventions? What can we do to minimize the risk of delirium?
I think that Michelle kind of went through it very well. I mean, we could dive into the Hospital Life program, which has been consistently shown to be beneficial for reducing delirium. I think the prehabilitation, identifying high-risk patients is definitely, if you don't have time, what do? I think you certainly can use that as a transition to the postoperative care and look at the medications. You know, the polypharmacy is definitely an issue that, particularly drugs that block the acetylcholine receptors and other drugs that we use, and being very careful about that. How can we, monitor anesthetic depth? There's been a lot of talk about BIS and the triple O and avoiding deep levels of anesthesia, with one study being positive, one study being negative. The most recent one, the BJA just published a couple of weeks ago, shows a benefit of targeting BIS versus deep anesthesia. We spent a lot of time looking at blood pressure, as you know, Feyce, and we know that we sort of treat everybody the same, right? We think that we should keep the blood pressure above a certain level, 65 millimeters of mercury. We know from our work, spanning now 10 years, is that how we define hypotension for a patient is really an individual diagnosis. If you start looking at cerebral blood flow autoregulation, we know that the cutoff of what will be tolerated varies markedly between individuals. So the best case scenario is you monitor that and maintain the blood pressure above it. We don't have those tools yet. Hopefully we will in the near future. But I think that hypotension definitely is a consideration to avoid. How you define it is going to be a little bit different because the patients we're talking about at risk has cerebrovascular disease. I think that by and large, most of these people, if you did MRIs on them, you would find small lacunae, maybe large strokes, small vessel disease, and they are very, very dependent on adequate perfusion in life and during anesthesia. So I think we need to definitely put an effort into better monitoring of cerebral perfusion and maybe titrating blood pressure. We recently had a paper published in the Journal of Clinical Anesthesia where we looked at this relationship between the individual definition of hypotension based on autoregulation and BIS. And what we found, the first author was my great friend and colleague, Charlie Brown, still at Hopkins. He was the senior author on the study. What we basically found is that when your blood pressure goes below the lower limit of autoregulation, this individual diagnosis of hypotension, this goes down. And when your blood pressure goes above the lower limit of autoregulation, this goes up. And we looked at other things like transcranial Doppler flow and our regional cerebral oxygen saturation with NIRS. And we also find the same thing, that these indicators of adequacy of cerebral perfusion are related to BIS. So when BIS is low, hypotension may be a contributing factor. So maybe BIS has value just to prevent getting the blood pressure too low, in addition to anesthetic depth, which go hand in hand. So I think, what you could do is be very, very careful with blood pressures, be very, very careful with brain perfusion, be very careful with anesthetic depth for both reasons, but start planning for the postoperative period and polypharmacy, everything that Michelle talked about with the Hospital or the Life program, making sure they could see, they could hear, they get the hearing aids back, cognitively stimulate them, either with an app or other ways, orientation exercises. And I think that that's the best we could do in 2021. And there are evidence to suggest that it'll be beneficial.
I have another question for you, Michelle.
Okay.
In terms of implementing a program like this, do you think the pre-op clinic would be the best home for something like this, since we are evaluating, assessing the patients in advance, and perhaps we have more resources to allocate to this endeavor?
We have a couple of different models. There's kind of three ways at our institution that patients get ready for surgery. One is primary management by the surgical clinic. One is through a nursing-driven pathway where the nurses that are trained in kind of important preoperative assessment questions and concerns will evaluate patients' response on a questionnaire and talk to them if more details needed, and then kind of get a sign-off from anesthesiology. And then there's formal preoperative testing clinic as well, which is kind of co-led by anesthesiology and internal medicine. So a lot of the surgeons will refer their patients to the official pre-op testing clinic. The other main pathway I said is this nursing. And I think that using some sort of structured preoperative evaluation is the way to go, because then it's consistent. It's kind of housed in one environment, kind of one pavilion, so to say, where all of the different surgery patients can kind of funnel through there, and it can be consistent and it can be tracked. The same message and the same instructions and everything given to the patients, instead of relying on it to be done the same way by a lot of different people, that it could, different pathways that it could go. So resources to do that are always an issue, I think, but in an ideal world, a central structured environment or pathway would be the best way, in my opinion.
How costly does it seem to be setting up something like this?
That's a tough question to answer because the cost is multifactorial. If we just talk about delirium, the most common complication after surgery in older folks, the cost with that is significant. I mean, it's been well published recently. And so if you think about that type of cost and what you're offsetting with really good preoperative patient education and optimization, to me, I think benefit is with investing in the preoperative process. But it is challenging because there's a lot of bodies that have to be committed to that, and FTE. I think most places have some sort of system in place for evaluating patients preoperatively. It would just be a matter of engaging with those folks and having a really, truly multidisciplinary discussion about how risky the patients that they normally see are for post-op delirium, so that they can get an idea of what the risk really is, and then try to build a program that tackles some of these things. There's a really nice discussion about this very thing and how to tackle implementing a program, because it's kind of recommended at this point that hospitals should have programs for identifying and dealing with patients at high risk for delirium that are having surgery. So that's the expectation, and a really nice article in the ASA Monitor this most recent month by Dr. Mythen about that. So it is costly to have a clinic that's run for the purposes of just optimizing patients, but I think the benefits that come from that are really worthwhile on a bigger scale. Less cancellations, less delays, less complications from the actual patient from a medical standpoint. And then also the delirium alone is really, really costly. So every time we can avoid that for the patients in the health system is a good thing.
I would like to invite my co-host, Dr. Sol Aronson, now to our panel.
Hey, Feyce.
So, hi.
And hi, Michelle and Chuck. Just to sort of take off on the question about value and whether or not we should be bold and stamp our feet and pound our fist on the table, or just kind of quietly go retreated to the corner about doing these things. I'm very much an advocate of standing firm and saying that the value proposition is very, very real. Those of our colleagues in the institutions that would help us stand up these programs need to stop looking at things in a myopic way. I think delirium is particularly exciting because of the increased length of stay and other adverse events as a consequence of our elderly population who undergo the perturbation of surgery is huge. It's huge. And the commitment is I think, more than justifiable. with that, Michelle, let me ask you this. I do know the guardrails of your study, because of the practicalities of how you enrolled, measured, were somewhat narrow, perhaps even more narrow than we could argue they should be. Ideally, how much runway would you like before surgery to bend the curve? If what you are showing, and I think this is what you showed, is that we can do stuff. We can actually do stuff to bend the curve. How much time before surgery is ideal so we can bend the curve as much as possible?
I think it depends on, for the purposes of just focusing on like a cognitive intervention, I think a pretty short period of time could work. I mean, as little as 5 hours might have a real benefit. So that could be an hour a day for a week or half an hour a day for 2 weeks, roughly. I also don't want to miss the opportunity to integrate an intervention like this into a bigger preoperative prehabilitation paradigm. In that case, ideally 6 weeks to a month, I think before surgery would be best to get more of that physical aspect, physical exercise component into it. But I don't think that it takes long periods of time to get some benefit from patients if they increase their physical activity and their nutrition gets better. But that 1 month time frame might be the sweet spot. That's just me completely speculating based on what I know about prehab and my intervention. The more the better, I'm sure. I'm sure there's not a point when it would be a waste of time for the patients at all to do this. So that's just my speculation. I think a month would be ideal because I would like to see it part of a more comprehensive program, a month to 6 weeks. But at a minimum, even just a week before surgery could have a benefit if the patients can commit to 5 hours or so of brain exercise. That might be enough.
Michelle, it's solid. Feyce, that our colleagues listening from abroad, particularly the UK, might be fascinated that we consider a month to be a long wait before surgery. Because they, particularly with COVID, the list have gotten. So that brings up the point is that maybe you could partner with places that have longer wait times and look at sort of like what is the optimal duration of prehabilitation. Because if you could make the point, if you show that it works, we could maybe bend the curve on the paradigms and how we care for early high-risk patients. It's going to take some work, but I think we could do it. You could do it.
I agree, and I think it's ripe for investigation. And Chuck, good point. I think that's an environment that may lend itself nicely to that kind of investigation. Earlier, Chuck, you made the point that prehabilitation is multi-dimensional and that it involves nutrition, it involves fitness, it involves many things. We certainly have gotten used to the biologic, if you will, guardrails of how long does it take for your hemoglobin to go up after you get a dose of IV iron. And those are very fixed sort of understood constraints. And we use those thresholds almost in a hard stop, way to justify inadequacy of a response. In the broader context of preoperative prehabilitation, there are a lot of things that we want to do. And it's rare that we would only single out cognitive calisthenics, if you will. And it may be an opportunity for us to sort of tag on these exercises along with the other things that we would be recommending. But I think it's really important that we take ownership of these sorts of questions because being healthy for surgery, being ready for surgery is what we should own. Downstream consequences of that are good. And everybody wins. The surgeon wins, the health system wins, the payer wins, and of course the patient wins. But somebody's got to pound their fist on the table and start, making that case and who better than us. And what I love about the cognitive dysfunction is it's so raw. Everybody gets that. And if we can make the case that we can do something proactively, do something to bend that curve, people will listen. So great work and such an important space.
Michelle, this past year, we've shifted to telemedicine for many things. Do you think that this could be like a starting point for a program like this, which would be probably less costly, but to start capturing patients and assessing the level of improvement and then obtain that information to tweak your part 2, part 3, if you will?
I think it has a big potential role. I'm very interested in trying to study that, because I think that that's one of the things that has come out of the pandemic for better, kind of rapid escalated telemedicine, from where it was, at least in my institution, to where it's at now. It was really incredible. And so I think that is a modality that we can really make a strong case for utilizing for preoperative optimization efforts, because patients just, they do better when they're checked in on. And there's lots of, products out there that are apps, and, they get the patient kind of cued into their care pathway, and they give them reminders and things like that. So I think that type of a maximization of what's available from a software application standpoint is really important to think about. I think telehealth can take that even to another level, because in my study, I'm well aware now, in a way that I wasn't at the time, that a lot of patients are showing up for surgery with a baseline cognitive deficit. It might be mild, but it's a significant portion of patients. It's 30% or so, give or take. So when I was coming up with the neurobics trial, I did not appreciate that. And the patients that have baseline cognitive deficits, I think, are going to require different types of strategies to really help them do whatever intervention is being given to them. Hopefully it's a more comprehensive program, prehabilitation program. So I think telemedicine, where you actually get to engage with somebody, would even have a benefit in some of those really high risk populations, because the neurobics trial was in cognitively normal patients. So we don't even know, based on the work that I've done yet, if the benefit will be there for people that have a cognitive deficit at baseline, which is a lot of our patients. It might be there. It might even be better for those patients. The impact that it can have, it needs to be studied. But I really see telemedicine helping target some of those really high risk groups going forward.
Michelle, you sort of raised a really interesting point, which is the stealth, appreciation of a patient who has cognitive dysfunction. It's probably me, and not aware of it. And yet they routinely come to a clinic to get checked in and evaluated. And our filters are not that great to routinely find out if they do have that deficit. If we build the filters to find those patients who would otherwise slip through the cracks, and we apply these tools to help them stay more crisp, at what point would we balance the expectation of a patient to do something on an app in a tele-digital way if their baseline cognitive decline doesn't enable them to do that? In other words, there's a balance between expectations being met and actual compliance being met.
The patients that have that pre-existing dysfunction are going to bring challenges to the table that I hadn't even thought about when I did the neurobics trial, because I didn't have those patients included. And so you don't know what they're capable of from an intervention standpoint, actually doing it, versus the compliance overall with an intervention. It's a struggle. It's come up in some of the discussion pieces that have been published around the concept of using preoperative cognitive exercise for the purposes of preventing delirium or minimizing the risk, because there's been 2 feasibility trials that came out while the neurobics trial was running. And they both, they kind of commented on some of the challenges of using cognitive exercise in patients, and especially those that have deficits at baseline. And, it's proposed that having a team of a care team where it's someone's responsibility to check in on that person regularly and make sure that they're doing what they're supposed to be doing would be a way to help them and to get them engaged with the program. But we don't know for sure. And we don't know if the best way to do that. So that's a question I think lots of folks that are interested in this are trying to navigate, is what interventions are we really serious about doing? And then how do we get those to the highest risk populations in a meaningful way? It's challenging. A lot of people are thinking about it, trying to come up with a plan.
Exciting open field running. Chuck, from the point of view of what you do and your expertise in blood pressure management as it relates to cognitive decline, if you had this information, somebody in the preoperative evaluation arena gave you, this information, patients who are red flagged, How does that change, or does it change anything that we should do in the perioperative period with respect to hemodynamic management?
Yeah, we kind of touched on this. I think that we need to push for improving our monitors. Okay, I mean, we could do that. That's going to take time for industry to get on board and regulatory agencies to get on board with that. But, I think you need to pay very, very close attention to it. And I certainly, if I had to choose one map, I think I would keep it at least 70, 75 in these high-risk people based on our own data. But are we talking about measure it every 5 minutes, every 10 minutes, every 15 minutes, or should we think about putting an A-line in or some other kind of continuous blood pressure monitor? I think that would certainly lower my threshold, because I think that precision management of these patients, you really have to pay attention to all the little things. Would you use a process EEG? I think there might be some added value. I know that it's very controversial, but I think that could provide complementary information on whether we're adequately perfusing the brain when you look at the relationship with end-tidal gas. And this is on a lot of it's my opinion, right? I can't necessarily support this with a lot of data, but I think we have to take very, very close attention to all the little small details of the patients, and then get them ready for the recovery room. Be careful with the drugs you give. Avoid drugs that are on the beers list. Get them awake quickly. Start stimulating them. Put the hearing aids in. Get the glasses on. Start orienting them. And all these little things, I think, can make a difference. And I think we got to get ourselves organized on how we approach this.
Michelle, what are your thoughts on that? Looking at it from a different lens, should we be more assertive in making decisions to monitor patients with arterial lines, even if we wouldn't have thought that necessary because of all the other constellation of patient morbid conditions? I mean, does this change your opinion about what should be our trigger to do things like that, making those decisions?
What it does is it gives me kind of pause when I think about my plan for a geriatric patient or a patient that's high risk for delirium. Along with what's been discussed already as far as watching the map, when I teach our residents, I'm really focused on hemodynamic stability, homeostasis. Wherever we started, I try to keep the patient, around that. And that includes not letting them be aggressively hyperventilated, that type of perturbation I see all the time unnecessarily. And I really think that when we disturb people's physiologic parameters without a really good reason in the OR, that's something that can put patients that are at risk for delirium, kind of kick them over into higher risk than we would like. I think there is some utility to looking at considering like a BIS monitor or something along those lines, like an EEG type monitor, of which there are different varieties. Again, it is controversial, like we talked about, but certainly at a minimum, adjusting your medication, your MAC for the patient's age, and having a plan for the way that their physiology can be affected differently by the medications. And then pain, we haven't really talked about that. Pain is in and of itself a risk factor for delirium. So uncontrolled pain does not serve our patients well. And high doses of opiates or other, kind of medications that can be sedating, that treat pain are not for their benefit either. So I think it gives me an opportunity to really advocate for a regional technique or something along those lines, that are multimodal analgesia. That's part of my plan too when it comes to these high-risk patients. So anytime I have a geriatric patient at all, these are things that I think about because their age alone makes them high risk for delirium. And that's what I try to talk to our trainees about is really thinking about keeping their physiology normal, not disrupted by our anesthetic, kind of treading lightly. I mean, that's one of the core tenets of the surgical home enhanced recovery programs, is that the surgeons do things in a minimally disruptive way to the patient and their physiology. And I think there's ways that we can do that with the anesthetic too, and our pain management plan. So that's what I try to focus on.
So when we're doing our sign-ins, for example, in labor and delivery, we're getting very specific about need for VT prophylaxis afterwards. When we're in the main ORs, we discuss if the patient is at increased risk for fire. Do you think that we should also be having that discussion about increased risk for delirium there when we're doing our sign-in or timeout?
I do. I think that it should be part of what we identify as being a real concern for a given patient, because it is the most common complication, in certain populations. So I'm all for that awareness and recognition. If we take a step back, what that actually means for anyone listening that is wanting to do, have a better practice at wherever they're at, their institution. That article by Dr. Peden, they talk about looking at your data, looking at your own patient population, because I think sometimes delirium gets kind of dismissed by some of our colleagues in the perioperative space because they just don't see patients after surgery. Half of delirium is of the hypoactive variety. So if you're in mind, when you think about delirium, as you're thinking of an agitated patient, well, that's only a subset of them. The other subset is hypoactive. They're not causing problems. They're not agitated and floridly delirious. And so a lot of the cases get missed. And so it's kind of thought that if you start looking for delirium and get an idea of how many of your patients are truly being impacted, then you can get buy-in from all these people and do something about it. And I personally do think that having like a discussion and during these different timeouts or huddles or things like that, I think delirium risk should be something that we focus on.
I just wanted to say something about that last comment that you made. I think it's so important. Delirium in the elderly patient, we know that is such a common occurrence that perhaps it has been normalized. So as practitioners, we kind of expect it. And we really don't think much beyond like, okay, let's not give midazolam or let's avoid opioids. We don't think of the interventions that can be done ahead of time. And that's exactly why we're having this conversation. But I think that the problem is that it has been normalized for so long that it's really going to take a major effort to shift our practice and to create awareness for something that impacts so many, and that there are things that can obviously be done to reduce its incidence.
No, you're 100% right. And the patients, I think, view it that way too. It doesn't, seem strange to them that mom or dad or grandma or themselves might wake up funny from surgery because they've just,
Correct.
Of course, it's the anesthetic but that's not true. People that are thinking about this that are a lot more experienced than me are proposing that like 30 to 40% of delirium cases in surgical patients are preventable. I agree with you. I think it is a little bit normalized and we need to work away from that because we could do better.
Well, I think in large part it's because until these data, Michelle, we were just willing to accept that as an inevitability. And I think we are now pushing back on that as something that we need to accept. And it's empowering and also very exciting. So we look forward to your continual studies and enabling us to understand this very, very important space even better.
Thank you, Dr. Hogue. It's been a great discussion. I look forward to seeing your work and more importantly, how we can really improve the care of our patients.
Thank you. Bye. Very nice to talk to everybody.
Top Med Talk. Thanks for downloading Top Med Talk. Don't forget to subscribe via your podcatcher. Don't forget to check us out on social media. We're on Twitter, Facebook, LinkedIn, and YouTube. And also, don't forget, Top Med Talk is the broadcasting arm of EBPOM, Evidence-Based Perioperative Medicine. We'd love you to find out more about that. If you check out ebpom.org, you can find low prices on some of the conferences we're organising around the world. Many of them are virtual and don't even involve you leaving your own home. Check out ebpom.org now.